So we heard in the morning session about the importance of having data to solve problems in immuno-oncology. Eric's reminded us of the importance of different components, and Mary has brought to the forefront the issues of longitudinality, the importance of having population-based data, and dealing with a very disconnected healthcare system. My name's Amy Abernethy. I sit on the National Cancer Policy Forum, and now I'm going to talk about infrastructure for clinical data exchange. In advance of my talk, I have a series of conflict of interest that probably at this point goes to the floor, but three main ones to mention. One is that I'm the Chief Medical Officer at Flatiron Health, which is a for-profit company focused on cancer data. I sit on the board of directors for Athena Health, which is a cloud-based electronic health record in the country. And also, I am the scientific co-chair for BMS's Phase 4 program for ipilimumab and also the PRO chair for Ipi-Nivo. So with that, a little bit about clinical data exchange. We were talking before and this morning with mass spec data and thinking about information that's coming off of our sequencers. And when we think about instrument data, this is highly structured information. It's highly analyzable. It comes in mass quantities. The problems are around sense making and storage and dealing with how we link patient privacy, et cetera. Administrative data is another important, highly structured data set. It's a bit messier. There are holes, and it's hard to figure out sometimes how to do it. But a lot of it is claims data. You can count patients, you can accumulate costs. And ultimately, these kinds of data sets themselves require us to think about management of structured data, learning how to use it, patient linkage, storage, et cetera. Clinical research data is another kind of data set where we intentionally structure it. Our protocols mean that things happen at standardized times. We fill in information on case report forms. We have somebody type it in to a database and then go to data lock and make sure it's available for use. And so these data sets are intentionally structured in a way that we can analyze them. But meanwhile, we've got this challenge that a huge volume of the critical information that's going to be able to solve the problem going forward in the future is locked outside of the clinical trial system and outside of places that are intentionally structured, and in fact lives in the day-to-day care of patients sitting in front of us. And so about 96% of the data that we're going to ultimately need to solve this problem is sitting in places that we currently have a hard time tapping into. We've talked a lot within the forum since 2009. I think we've been having conversations about the importance of the electronic health record in helping us solve this problem. It's sometimes structured. There was the HITECH Act, part of the ARA bill, healthcare reform that helped to launch the uptake of electronic health records. Some of that information is structured, like demographics and laboratory information, but a lot of it, as Mary pointed out, lives in places that are currently hard to get to and may not even be accurate. Yet, if we rethink about the electronic health record, it hopefully will serve as a backbone to how we structure information, going back to what Eric reminded us about the importance of having information structured in a way that makes good sense to us and is rapidly analyzable and we can work with, like the Rubik's Cube. So I want to come to a conceptual model around electronic health record data as one way of potentially going forward. You know, we often talk about the electronic health record, and we tend to point to the slide on the left, the stuff that lives in digital data feeds, such as laboratories and demographics. But in fact, like Eric was talking about, the electronic health record actually serves as the massive filing cabinet for the day-to-day care of patients. And in fact, much of the information lives on the right. We spent some time at Flatiron trying to quantify how much of that, it's over 50% so far that we can tell, lives in physician notes, path reports, radiology reports. Perhaps the mortality data resides in the condolence card. As Mary pointed out, much of the information about the patient is in holes that might live in another health system. But in fact, in taking care of the patient, the records usually come. It's just a big dump of PDFs that you have to figure out how to wade through. And so much of the electronic health record, if we're going to use it in our future, lives on that right-hand side. If we focus a little more on the left-hand side, what we see is that even when it is digital information. It's messy and sloppy. This is one table from one clinic in North Florida, where what we were trying to do was get to a single concept of serum albumin. These were all of the different rows coming in for different concepts of albumin. Some were urine, some were CSF. You actually have to get to one concept. And then these laboratory feeds change almost every month, a lot like Mary referred to, and so you have to constantly keep up with the cleaning. But in fact, this is standard normalization and harmonization. We can deal with this, and it's been going on for a long time. Over here on the right-hand side is where there's been a lot of work by different companies, as Mary alluded to, but really where a lot of the important data we're going to need reside. Here's an example of a KRAS test. I picked KRAS based on this morning's conversation. You see that there's information that's been redacted. It's slightly tilted because it's a scan that's been now entered into the EHR as a PDF. And in fact, you've got to pull out some key information points, such as the KRAS status, the test result, the date the sample was collected. There's a lot of words on the page, but only a series of critical variables that are going to be needed for the overall data set. Ultimately, one of the key tasks if we're going to make electronic health record data be a part of our version 2.0 of building population-based registries for the future is figuring out how to deal with this. At Flatiron, we have one way of dealing with it. There's others out there. Specifically, our belief is that you actually have to have real people who understand cancer data, look at every single one of those documents and pull out those key data points, and so that's what we do. We use essentially a case report form model and sort of a tumor registry model, but use technology to enable real people to do this in real time. I'm not going to spend any more time on how we do it at Flatiron, but suffice to say, whether you're trying natural language processing, you're trying technology-enabled abstraction, or some other approach, critically right now what's happening in the tech industry is some combination of technology and people and capabilities to really dig in to that unstructured data and fill in those variables. So then what happens is your electronic health record starts to serve as a source of critical information and basically populate those registries of the future. The other problem, though, as we've just heard, is that we live in highly fragmented systems. For 2 decades or more, I worked at Duke. UNC was 9 miles down the road. It was still faster to get in the car and drive your medical record down the street than it was to try and figure out how to exchange information back and forth just 6 years ago in my clinic. And now what we've been working on, at least at Flatiron, our approach to it is to aggregate data from the back end. There's different ways to do this, but critically you've got to aggregate information from across systems so that you've got one set of population level data that you can deal with. And solutions are out there and coming quickly. So then what you end up with is a central repository. We heard about the data warehouse of processed electronic health record data that now can be linked to other data sets. And that linkage to other data sets, including immunology data, starts to serve a critical purpose of creating an information backbone for our future. We heard before about organizing data around the patient. Perhaps a mental model to take that forward is the following. So a population, a registry, is simply an aggregation of a whole bunch of individuals. Single patient stories pulled together in order to create the overarching story. So if we take people with lung cancer, one person who was diagnosed with non-small cell over left undergoes surgery for early stage disease, develops metastatic disease, perhaps gets tested for EGFR and ALK, and then starts first-line therapy. The person progresses on first line and gets tested for PD-L1 expression and maybe also the T790M mutation for EGFR, starts second line, deteriorates, and perhaps passes away. We can think about individual patient stories by the diseases that we already know, including the long-term stories in immuno-oncology that we're hoping to see in our future and we've seen in bone marrow transplant in the past. We can now start hanging these different kinds of data sets off of that patient story backbone to organize the data in a way that allows us to set up registries where the sources are varied. So first, structured electronic health record data comes in to fill in some of the spaces, such as gender or duration of therapy. Then we can layer in unstructured data, going to the radiology reports, the pathology reports, the medical case notes to fill in critical information, such as T&M staging, sites of METs, type of EGFR mutation, response, PD-L1 expression testing. External data sets beyond the EHR can fill in things like the immune profile, stories about what happened with the hospitalization, and information about date of death. And algorithms aggregating information can fill in information like time to recurrence, line of therapy, and also a consensus date of death, since mortality data is critical to all of our data sets. Importantly, we have to set up our data sets to be consistent with our mental model of data. Clinical trials data might be one way to think about that. And here's how you might think about a clinical trials data set now using EHR data as a backbone and filling in all of those different holes from different sources. And so if we take, for example, the first row, patient A, and we pull out the biomarker data for PD-L1, we can actually understand how patient A performed on a PD-L1 expression assay, and even understand that to the level of source, quality, and provenance. So for example, in that patient, for that biomarker, this is one example, a real one from Flatiron, that biomarker test, PD-L1 expression, was abstracted by a particular abstractor, Sue Smith, not her real name, on January 5th at 10:10 a.m. We know what documents she reviewed in order to pull the data out. We know what clinic the data came from. We know how good she is, including how likely she is to compare to her peers who are other abstractors, how likely that particular biomarker test approximates reality, and completeness for that biomarker test. And there's audit trails for all changes. These are the things that we're going to need for our data sets going forward in order to make sure that we understand the source and we have a clear audit trail to follow them over time. You also need to be able to understand the quality of each data point. So for example, here in the top panel, what you see are variables relevant to non-small cell lung cancer. In the middle are if we look at structured data only, and on the right is if it gets filled in with unstructured document review. And for example, the PD-L1 expression assay is almost never seen right now in structured lab results, but we can find it on PDFs of PD-L1 expression testing in the charts. Similarly, we actually have to think about every single variable as its own IPA. It's artisanal variable where we think about for example, the inter-abstractor agreement of a particular variable and how likely that variable approximates reality. This is sites of METs data, and what you see here is that bone METs are highly likely to be easy for an abstractor to pick out. So the inter-abstractor agreement is very high and the kappa is high. Lung METs, where it's hard to tell if this is a MET or an infiltrate, there's more disagreement and a lower kappa. And you should be able to understand every variable in your data set with that kind of quality. And I can tell you that in data sets going forward, that's what it will look like. So that ultimately you get to data sets that are EHR-based, but population-based, always on and always organized and ready to go for you, and up to date. What do I mean by up to date? I think that in your future, what you're going to see are data sets that are available to you within the month with full information already organized and ready to go. So what's the impact of having highly organized data and what this future might look like for you? I'm just going to give you a couple of examples that I pulled out this morning. So this is non-small cell lung cancer. This is a cohort of patients we've been following with 22,000 individuals. Some of them are coming from academic centers and 20,000 from the community. And you can just see the representation across the states. Looking at this cohort, what we see is 25% have squamous cell histology, 12% are non-smokers. We tend to watch these numbers on a month-by-month basis as the data sets come out. Whoops. What we see here is PD-L1 expression testing. We've been monitoring PD-L1 expression testing since June, because basically a lot of things happen in June when ASCO happens. And what you see here is in non-small cell lung cancer, the rate of PD-L1 expression testing has gone from 3.5% to 5.2% by December 2015. And we see about 46% have evidence of PD-L1 positivity, with a broad array of different kinds of PD-L1 assays being done and what positivity means if you drill down and look at the actual reports. Looking across the country at the kinds of drugs that patients are receiving, what you're seeing here is a histogram month over month, December 2013 all the way on the left, 2 years of data, December 2015 all the way over on the right. These again are all patients with lung cancer being treated, and specifically PD-L1s. And as you would guess, we start to see PD-L1s being used in the United States approximately March 2015. That's where the white just starts to come in. And there's 1.4% of all treatments for non-small cell lung cancer being used in this cohort, representing PD-L1s in March. And by December, 22% of all drugs being given in the month of December were PD-L1 therapies. Why is this important? If you're planning your control arms for your clinical trials, think how quickly the background story is changing as we move forward. If we look, for example, at patients just in the first-line setting, again, that little sliver of white up at the top shows you the PD-L1 utilization. In the first line, it's less than 5% since March of 2015. But in the second line, it increases from 2.6% in March of 2015 to 44%. If we look at melanoma, this is a cohort we're following of a little over 1,700 individuals. And what we see here is the Duke blue is ipilimumab, the UNC blue is chemotherapy, the brown are PD-1 inhibitors, and the gray are BRAF inhibitors. These are all treatments being given in melanoma. Looking here in July of 2015, what you see is that arrow on the left is when the New England Journal article was put out of Ipi-Nivo, and what you see is between July of 2015 and December, the increase of the combination utilization to 9%. The approval didn't happen until January. I was actually trying to get you the January data. It's supposed to come out in 2 hours. If we look at first line, BRAF wild type, what we see over there in December 2015 is 19% of patients getting treated in the melanoma setting, first line, BRAF wild type, getting Ipi-Nivo combo. Again, the background is changing very, very quickly, and we need real-time data sets that tell us what the overall story looks like in order to inform our future. So putting it all together, I submit to you that electronic health records and their increased utilization in the country can serve as a backbone for information, and we have to solve that clinical data exchange problem. That as we get processed EHR data that's organized and structured, we can link in all kinds of data sets that are important to us, including the overall immune profile of the patient. And that will then ultimately start to create the full story around the individual. And that also then helps us to move forward with an organized concept of this messy concept of big data. A couple of policy thoughts here. So policy solutions should demand interoperability. There's no question in my mind. My patients should not have to get in the car to go 9 miles down the street to UNC. We should be able to move our documents back and forth in order to take care of our patients every day. But interoperability does not solve the unstructured data problem. We still have to solve that problem, and I'll submit to you that we've actually practiced when I was at Duke, trying to have doctors better enter information, and what we learned is that we got dirty information in by requiring doctors to do it, but rather if we let doctors take care of patients and find solutions around them, it was far more efficient and the data are much cleaner. We need to recognize that unstructured data processing is costly, and that's going to be something we're going to have to talk about and deal with. It's kind of like oil. It's got to be refined to be useful. We've got to reward sharing and working together. We need to support efforts in data linkage. I'll tell you, one of the things I've been most fascinated by since I've been at Flatiron is how hard it is to de-identify linked data and how long it takes us to work through that frame. We need to think about new ideas like data clean zones and other ways to solve this from the policy standpoint. And finally, we need a workforce. We need a workforce that is facile in dealing with these data sets. We need doctors who are ready to be a part of this in the future, and that's going to need to be fundamentally a part of our future. So with that, I say thank you and introduce Steve Arabu from BMS, who will take it forward.